Good evening, everyone. Thank you so much for joining us for the second session of Child Mental Health Community of Practice. And our topic for today's session is aggressive and challenging behaviors. Sorry. So before we start our session officially, I would like to acknowledge the country. Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place. The Wurundjeri, we Wurrung people, the Boon Wurrung people, and Wadawurrung people. We pay respects to elders past, present, and emerging, as well as pay respects to any Aboriginal or Torres Strait Islander people in the session with us today. Before starting the session, just some community of practice guidelines. So we agree to stay on mute unless speaking, raise your hand to speak, keep conversations confidential. If possible, keep camera on. Introduce yourself and your role when speaking. Share ideas and promote everyone's participation. Acknowledge that we have varied learning needs and interests, and ask questions, and no question is silly. And we always love you asking questions. One important thing that, during the education component, please ask questions via chat box. This session is being recorded. Please ensure you join the session using the name you registered with so we can mark your attendance. Certificates and CPD will not be issued if we cannot confirm your attendance. So if you have already joined in with a different name, just some information on how to change your name in Zoom meeting. So click on participants. If you are logging in through an app, then click on your name. And if you are joining in on a desktop, then hover over your name and click the three dots. On Mac, just hover over your name and click more, and then click on rename. Enter your name, the name you registered with, and click done, change, or rename, whatever is applicable to you. And it's all done. Sounds very complicated to me. So our speaker for today is Dr. Prakash. Dr. Prakash is a senior consultant child and adolescent psychiatrist at RCH with over 20 years experience. He has worked in managed general and specialist clinics with child psychiatry in metropolitan and regional public mental health services. Prakash has worked with children and adolescents from 4 to 18 years of age, assessing and managing a variety of mental health issues. Bit about me, I'm Saha. I've been working as a GP in Sunbury for about 9 years, and I'm quite passionate about child and adolescent mental health and chronic disease management. I'm just gonna head over to Vanessa to check if Dr. Prakash is here.
Yes, Prakash is here.
Sure. Hi, Dr. Prakash.
Hello, Dr. Saha.
Would you like to do, would you like me to do the slides, like move the slides for you, or are you going to share yourself?
I can do either. Yeah.
It's up to you.
I can do either. Yeah, that's fine. I don't mind either way.
Okay, I'll just then do it since I have already shared it. So handing it over to you. Thank you so much.
Thanks a lot.
Is it okay? Is it working?
Thank you. Thank you. I guess what we would probably talk about initially is the progression of behaviors from infancy through to adolescence and into adulthood in terms of the development of regular oppositional defiant disorder, conduct disorder, and antisocial disorders. So studies have shown that overactivity and irritability seen in infancy can lead to often problems from very early on. These are temperamental vulnerabilities that have been known to lead to argumentative and defiant preschool behavior, then leading on to physical aggression and stealing in later childhood and antisocial behavior in the adolescents and adults. About 10% children with oppositional defiant disorder eventually develop antisocial personality disorder. Almost every child with a conduct disorder probably had an earlier ODD, but only a section of, only a subset of children with ODD develop conduct disorder. Thank you. I'll stick to assessment formulation and some management here. The rest of the information is in the background reading slides. It's really hard to cover all of this in 20 minutes, so I'm going to try to rush through as much as I can. A comprehensive assessment of a child or young person with an antisocial behavior or conduct disorder involves trying to see the child or the young person on their own without their parents, but also involving the parent and carers and third parties like school, welfare officers, or other people that the young person may have a relationship with, to try to get a comprehensive assessment, to get as much information as possible in the early stages. Thank you. The assessment will involve, apart from eliciting the symptoms of oppositional defiant disorder and conduct disorder, particular things such as the pattern of negativistic thinking, hostile behavior, defiant behavior, aggression to people, animals, destruction of property, deceitfulness, theft, serious violations, really looking for that information. And we know now that we certainly see at the RCHED very young children being brought in by the police having committed serious violations of rules. And so I think we should not pull back. We should not hesitate from making those inquiries. The child sitting in front of you might look very young and innocent, but I think it's really important for us to sort of ask about those things, particularly in children that frequently disappear from home or school. The other thing to sort of assess is the parenting quality, the capacity of the parents to both act as a secure base and a safe haven. So you look at the kind of circle of security, the capacity of the parents to send the children out to explore the world appropriately, having taught them their boundaries, and then to bring them back in and debrief them, help them regulate if they are upset and things like that. So what's been the parenting quality? What's been the experience of parents being parented by their own parents early on in life? Any history of past or current mental health or physical health problems like learning difficulties, disabilities, neurodevelopmental disorders such as ADHD and autism, neurological conditions like epilepsy or motor impairment, mental health problems like depression, post-traumatic stress disorder, bipolar disorder, which you might start to see from 12, 13 years onwards. I have seen one or two younger children. And I'm not talking about a pediatric bipolar disorder sort of issue. I'm talking about real sort of bipolar disorder needing lithium and valproate and that sort of, quite kind of clear-cut bipolar disorder. Substance misuse, communication disorders like speech and language problems. Thank you. The other thing is to assess the risks faced by the child or young person, to develop a risk management plan, also to look at self-neglect, self-harm, suicidal feelings, because that can be quite frequently they can co-occur with violence and aggression. Presence of physical, sexual, emotional abuse is quite important as well. There's a significant correlation between physical and sexual abuse and violence and aggression. We must look at the parent-child relationship, positive and negative aspects of parenting, including any coercive discipline. Also within the family, look for family violence and aggression. Both. They are abusing people and they're also being abused. Sorry. Yeah. Parent well-being, including mental health, substance misuse in the parents, especially during pregnancy, but ongoing, and criminal behavior in the parents as well, creating negative role modeling. Then we look at kind of the formulation across 4 factors, the same that we would use in suicide and self-harm as well. Risk status factors really are the static factors. These are the factors that are likely to increase the risk of the young person. They're not the sort of things that you would directly see in the young person, but you would see them as part of the sort of the overall background risk, if you will. They do not directly lead to an increased risk, but they are the overall background risk factors. They're static factors. These are past history of offenses, substance use history, history of violence whilst intoxicated or withdrawing, history of violence when not affected by substances as well, male gender, history of aggression, mental illness, symptoms of psychosis, depression, anxiety disorder, ADHD, oppositional defiant disorder and conduct disorder, exposure to violence in peer groups, preoccupation with violence on television and video games. I have a few slides in the background reading slide set on why there is a potential increase in risk of violent and aggressive behaviors on, in young children who spend a lot of time playing violent video games. Exposure to family violence, low IQ. And then there are the risk state factors. These are the factors that are changeable. And within that, what we do is we use what's called as a chronological approach. The chronological approach looks at the risk of aggression, whether the person has had a history of aggression in the last 24 to 48 hours, 1 week, 2 weeks, 2 months, longer than 2 months, or up to a year. And we actually the closer to the index episode at the time of the assessment, the history of aggression or violence is, the greater the risk of aggression or violence. So that's sort of quite important. The factors will include ongoing symptoms of a mental illness, like a second person command, auditory hallucinations, withdrawing from substances, remaining unhappy and being angry, paranoid, having persecutory delusions. There are several warning signs of an impending aggression, and we use the acronym STAMP, that they might stare with the prolonged glaring at the doctors or other staff in the practice, be sharp, sarcastic, loud, argumentative sort of tone. There might be anxiety symptoms like flushed face, heavy breathing, rapid speech. They might be muttering, talking under their breath. They may be pacing up and down the area, and all of these things might be seen. The protective factors and available resources are those factors that decrease the risk of aggression. These include female gender by and large. They are slightly less risky with regards to overt aggression, although there are female gangs apparently of older children and teenagers in Melbourne that have fights between each other in the CBD, I'm told. But generally females are less frequently, girls are less sort of represented in this sort of overt aggression. Higher IQ, intolerance towards deviant behaviors, positive social orientation, close relationship with the parents, warm supporting parents who are prepared to sort of attend sessions of family therapy and work with the young person. Peer and social factors, that is, they have pro-social peers who have a commitment to the rule of law, to learning and education, good response to medication in the improvement of psychosis or neurodevelopmental disorder, like if you're using risperidone, good initial response to risperidone is also a good indicator. It's important to develop a care plan with the young person, parents and carers, that looks at their specific profile, and if they have ASD, if they have high functioning ASD with a fixed sort of homicidal thought or an aggressive impulse, then how do you treat that versus a very impulsive young person who's more likely to act aggressively in reaction to immediate situations, which is a more impulsive type aggression. So we'll have to create a care plan based on all of that. Any personal, social, occupational, housing, educational needs, the needs of the parents, the strengths of the child or young person and their parents or carers. And treating comorbid mental health problems, looking at language and speech disorders and things. And I suppose the important thing is to engage the young person and the parents and carers, and that is quite hard in this population. And so some of the things that we have to look for is, what is their experience of having this diagnosis, what's been their experience of engaging services, their previous experiences of having interventions, nature and severity and duration of the problem. The longer the duration, the less likely they are going to want to engage in treatment, the harder it would be to treat as well. What impact the disorder has had on educational performance, like have they not been attending school, and as a result, have they been sort of not learning much, and things like that. Chronic physical health problems, social or family factors that may have a role in the background, any coexisting conditions. It's important to take the account of the preferences of the child or young person and also the parents when making referrals. They might want to work on something. So something that they feel is tangible and something that they feel they need to work on. So whether that's anger or whether that is aggression or whether that is impulse management, acting without thinking, that sort of stuff. They might have some specific things that they would like to change. It's important to see if there is something like that, or their mood, that sort of stuff. So if there is something that we can agree on with them and say, okay, so we might not be able to change all of it, and there may be lots of things that you may not want to change, but if we can just have one or two things that we can work on, that would be good. In this context, I think it's useful to kind of mention the DSM-5 disruptive mood dysregulation disorder. The ICD-11 has a description of something like that as well. So severe temper outbursts at least 3 times a week with sad, irritable, or angry mood on a daily basis. The reaction of this anger and aggression is bigger than what can be expected for that situation. The child must be at least 6 years of age before the diagnosis can be made. Symptoms often begin before the age of 10. Symptoms are present for at least a year. The child has problems functioning in more than one situation, home, school, and or with friends. With regards to the treatment, with the younger age group, 3 to 14 years, the predominant thing is psychosocial interventions, but with the older teenagers as well, psychosocial interventions are definitely possible. With the younger children, there are child-focused programs, parent and child programs, parent and foster carer or guardian training programs are there as well. And with the older teenagers is the multimodal interventions that involve working with the school, working with the family, working with other agencies that are involved. As far as the pharmacological interventions are concerned, they do not obviously specifically help for the behavioral management, but it's more for underlying anxiety, underlying irritability, and things like that. So there are some medications that are useful in managing the severely aggressive behavior in a young person with conduct disorder. And obviously the pharmacological management of ADHD is quite well established. In terms of the medications with evidence, the evidence base amongst the antipsychotics is for the typical antipsychotics such as haloperidol, and then the older second generation ones such as risperidone. The others have come in more recently, like olanzapine, quetiapine, and aripiprazole. We can talk about them if there are particular questions. In the treatment of the anxiety problems, we could use things like atomoxetine, reboxetine in combination with stimulants for ADHD. And then the SSRIs, then there's lithium carbonate, carbamazepine, sometimes that is used as well, and sodium valproate. So that's the sort of evidence base for the different medications. Risperidone obviously having more evidence base, usually used for short-term management of the severe aggressive behavior in neurotypical children and adolescents with conduct disorder. It's quite different to its use in autism. I guess the things to remember are there is the metabolic syndrome, extrapyramidal side effects, cardiovascular side effects due to prolonged QT, although that risk is quite low in risperidone compared to other antipsychotic medications. There is increased plasma prolactin and all sorts of other adverse effects that young people often report. So again, I just wish to stress that the use of risperidone in a neurotypical young person with conduct disorder is quite different. It's considered more for the short-term management of the aggression. These are just general things that we normally advise. Often it's difficult, especially with these young people and children. And if they have ASD as well, then it becomes harder to engage them in these examinations. But we would normally say at baseline, and weight and height and waist and hip measurements, pulse and blood pressure, fasting blood sugar and HbA1c, lipid profile, look for any pre-existing congenital movement disorders, assessment of the nutritional state, diet, and level of physical activity, and then repeat that. The psychiatry journals say that we have to do these things every 3 months, and I know most GPs and pediatricians and others will not do them. It's simply not possible. It's simply difficult to kind of bring these young people and get them to comply with blood tests, and let alone physical examinations. Blood tests are kind of really hard. Anyway, so if using in a neurotypical young person with conduct disorder, it's useful to kind of review the effects of the risperidone after 3 to 4 weeks. And generally, the guidelines say if they don't work, stop it. But on a case-by-case basis, we might decide to continue on with them. Again, happy to take questions about dosing and all of that, and titration. The effect sizes are more for risperidone, and next for the typical antipsychotics, then the stimulants, and lithium, and SSRI. So this is for aggression in conduct disorders. So with the behavioral plan, we talk about 3 things that are drivers, that are motivators, which is the gains and benefits that the young person might have. Why has violence been an attractive thing for them? Are they seeking reward? Are they wanting to, achieve a distance from other young people at school or elsewhere? Are they wanting to achieve proximity? So they're wanting to be accepted by somebody, but when they feel rejected, then they act out in anger. Is this justice, revenge, profit, control, self-esteem, emotional arousal? So these things are kind of really difficult to sort of iron out. There are some good functional behavioral analysis tools that can be used. The other sort of slide set has got links to some of them. There are the disinhibitors, like symptoms of ADHD, symptoms of psychosis, substance use. These can be disinhibiting factors. Also, apart from that, they can be certain temperamental traits like negative and nihilistic traits, a lack of guilt, a lack of empathy, a lack of anxiety for the consequences, that sort of stuff. And there are destabilizers, which are acute symptoms of things like psychotic disorders or disturbed cognitive function due to one reason or the other. Perseverative thoughts, like you might find in a young person with ASD, they have really strong, perseverative, fixed sort of, kind of thinking. It's almost like a delusion, but it's not a delusion, of wanting to be aggressive or do something. There are strategies to manage each of the above factors, including sensory techniques, behavioral techniques, PRN medication, regular medications, and we need to kind of look at all of them and then review the plan every so often. Thank you.
You're on mute,
You're on mute.
Saha.
You're on mute.
Yeah, thank you so much, Dr. Prakash. Thank you, Vanessa. I was just saying that I was going through some health pathway slides regarding, just behavioral management in kids and how. So I found this one particularly about, a different sort of a cohort that Dr. Prakash talked about just with the kids and preschoolers. So I'm trying to just find it because it was interesting. Sorry. Here we are. So came across some really, interesting tools while having a look at it. I'm not sure how many of you are aware of this app or used it before, a Child 360. Please feel free to actually unmute yourself and tell me about it if anybody has used it before, because I would like to actually, play with it a little bit later on, as I only stumbled upon it just today. And just this strength, they have this nice link to strength and difficulties questionnaire. Dr. Prakash, do you use this? Would you recommend GPs using it? Is it like a useful questionnaire?
Look, it's a dimensional questionnaire rather than a categorical tool. So it's more useful as an kind of a monitoring measure rather than an immediate measure of the risk of aggression or anything. It's more like a monitoring measure. Yeah, and increasingly we are becoming aware that rating tools, rating scales that measure any mental health risk factor, whether that is self-harm or suicide or aggression, in terms of low, moderate, and high, are not very accurate. But there are some tools you can use. For example, if you're treating someone for ADHD, then the SNAP DSM-5 or SNAP-4 is a useful tool that can be used to kind of monitor. That's it's free of charge, free of cost, and it's downloadable from adhd.net.
Yeah, thank you. Has anyone used that app, just out of curiosity? Have you heard of it, Dr. Prakash?
I haven't, no.
Yeah, okay. It's actually developed by National Workforce Center for Child Mental Health. So I think I'll go and have a look at it and report back next time. So just moving